Hey everyone, it's the dawning of a new era. It's our final lecture. Can you believe it? Um, let's see. All right, we're going to finish talking about small animal medical nursing. And there is so much I'd love to discuss with you and talk with you about, but just no time, no time. So you'll encounter all these amazing um, clients and critters and bizarre cases on your own. So I guess I shouldn't try to spoil it for you. I know there's a few spots in here um, that I wanted to add something. So we'll make do. I wanted to begin by showing you this case. This is Claire. She's a 7-year-old female spayed standard poople. Okay, that's one mistake. The chief complaint for this poople was that she had chronic diarrhea. She seemed fine otherwise, maybe a little lethargic, but otherwise fine. Well, what would be some good questions you would want to ask her? Well, of course, you'd probably ask her things like, um, what's her vaccine status? Is she on parasite control? Um, I'm I'm going to interject just some things I do. I'll write in the record no known travel ticks and toxins, or what I call the 3 T's. And I do that just to remind myself to ask people, has she gone anywhere? By travel, I don't mean, you know, Arizona, I mean the dog park, the river, a lake, something like that. Um, Asking about ticks, because sometimes they will say, oh, you know what? We found a tick on her 2 weeks ago. Toxins, just did she get into anything? Things like that. No change in diet. She eats a commercial dry food. Okay, I meant to, that's from last week about call zoner. So ignore that last part there. Objective, we do our physical exam. This is what I write for just about this is sort of my template for a moderately normal physical exam. I got my temperature, my pulse, mucous membrane, CRT. EENT stands for ear, eyes, nose, throat. So eyes are clear, no discharge. There's some hair in the canals, but I made sure I could see the tympanic membrane. Um, some periodontal disease. For cardiovascular pulmonary, no MS, should say no MA. So that's no murmurs or arrhythmias. The eupnic means breathing well. For urogenital, gastrointestinal, there's no apparent masses or organomegaly. Check check the rectum, check the vulva, um, watched her walk, felt her musculature, checked for CP deficits, and so I write ambulatory ×4, no apparent neurodeficits. Checked her skin, checked her lymph nodes, so I write a full clean coat. No peripheral lymphadenopathy. That just means the lymph nodes were all normal size. All right, well, remember assessment is you can call it a problem list. Different places you go, they may not call it a SOAP, but it's still, they're going to follow the same sort of these same steps. So even though the veterinarian is the one who's going to diagnose, what do you think some possible etiologies are for Claire's diarrhea? And why do you think it's important for you to generate your own list? Well, let's look at what I wrote in the record. I write this for most cases of diarrhea. I start by breaking it down in my mind into gastrointestinal versus extra gastrointestinal causes. And by that I mean sometimes there are problems that have nothing to do with the gastrointestinal system, but they manifest as diarrhea or vomiting or other gastrointestinal signs. So I wrote dietary indiscretion. That means eating something she shouldn't have eaten. Food intolerance, immune mediated. That could be something like inflammatory bowel disease. It could be something infectious, a virus, a bacteria, a parasite, a fungus. In some species, I would add prion to that list. Neoplasia, they could have intestinal lymphoma, for example, foreign body obstruction. And I write open. Open just means there's probably other things that I haven't thought of. So that, again, just is what something I write to just remind me that there's a million, not a million, but there are a lot of possibilities. And then for the extra GI causes, there could be hepatopathy, just as a general term for some sort of liver disease. You know, it could be hepatitis, it could be cholangitis or cholangiohepatitis, it could be liver failure, any number of things. Kidney disease, endocrinopathies just means some sort of disorder of the endocrine system. HAC stands for hyperadrenocorticism. I got hypoadrenocorticism, diabetes mellitus, hyperthyroidism, hypothyroidism, neoplasia. Again, totally outside the gastrointestinal tract, but they could cause diarrhea. So, and why do you think it's important for you to know? Well, one, it gets you thinking about what are some things that I need to be doing for this patient. We don't know what her diagnosis is yet, but it's like, we got diarrhea, we got fatigue. What if it is liver failure? What if it is kidney failure? You know, are we gonna need a catheter? Are we gonna need fluids? Maybe I should get stuff out for blood work. Maybe prepare for an ultrasound, right? And I've heard, and believe me, I do not mind when my, coworkers say, oh, maybe it's this, maybe it's that, because sometimes they mention something that I totally forgot about. So it is helpful. It's helpful to have as many minds thinking as possible. So we do the minimum database. We do a CBC, chemistry panel, do a fecal, ova, and parasite with Giardia, ELISA, radiographs, right and left lateral. Anyway, it's all normal. It's all normal. And we will talk later about the very serious thing that was wrong with Claire. So here we are in our final small animal medical nursing lecture. We're talking about endocrine disease, immune-mediated disease, and then we'll say just a little about infectious disease. We'll describe the etiology, pathogenesis, clinical signs, treatment considerations for common endocrine and immune-mediated disorders, and then we'll say a little bit about infectious disease. We've actually talked about infectious disease starting back in your very first semester. It's shown up in every course, but of course there's so many infectious diseases, and the last part of the book is a little annoying. It just kind of crams 30 infectious diseases into this one table. So I thought, well, I could lecture on a few of them, but we're almost done. You have a lot on your plate without me adding even more to it. So we'll stick to what the book focuses on. All right, so these are the main endocrine and immune-mediated diseases that we're going to talk about. But there are many more. There are many more endocrine diseases. We talked last year about Andre the Giant. He had an endocrine disease. Diabetes insipidus, or what they call water diabetes. Totally different type of diabetes. Has nothing to do with diabetes mellitus other than you are polyuric and polydipsic. Last year, we talked about metabolic bone disease of reptiles. That's a problem with the parathyroid hormone. But we're not going to talk about those endocrine disorders. There's a great little video. We're not going to watch it, but I think you watched it last year. If you want to watch it again, it's a nice sort of overview of hormones, but I'll give you an overview myself here. So you've got these. It's a funny system, your endocrine system, because they're not connected. You have all these glands, and it's like they're all separate little islands. Um, they help control metabolism and growth and sexual development and dealing with stress and calcium levels. They do so many different jobs using hormones. This mentions some of them here. Um, this picture of the dog shows more. We've talked about them last year. A helpful way to think about them is that the endocrine system is one of the two great communication systems in your body. You have this rather slow but long-lasting system. That's your endocrine system. And then you have this lightning fast but short-lived system, the nervous system. And they're both working together. They're both working constantly, this sort of constant message of homeostasis to keep everything in balance, even though things are constantly moving. This over here shows, a gland with hormones, and then there's some target cell that they're going to activate. Over here, we're watching that lightning fast movement through the nervous system. And these two systems are not independent, they interact. Your nervous system interacts with your endocrine system. When a crying neonate is heard by its mother, that nervous signal of hearing translates into the release of oxytocin to allow milk to be let down. So and we've talked about that last year. Okay, so partly as a review, just remember the word endocrine versus exocrine. Exocrine means it's traveling through some sort of a duct. That's not what we're talking about today. We're talking about endocrine, sort of these ductless chemicals called hormones. The pancreas, you learned last week, has exocrine functions. It releases these digestive enzymes into the small intestine. But today we're talking about endocrine. So everything gets secreted into the bloodstream. There's no duct. And hormone, remember, it's a really broad term. Some hormones are quite large, some are quite small, some are steroids and they can travel across the cell membrane. Others cannot. They're just different shapes and sizes. They have a lot of things in common. They're going to come from some sort of a gland, travel through the blood, and reach some target, which is going to have a receptor. The receptor may be maybe extracellular, like you see here, but sometimes the receptor is actually inside the target cell. And the target cell varies, calcitonin and parathyroid hormone, they mostly focus on calcium. So they affect the kidney and the intestines and bones, but that's kind of it. But there are other hormones like cortisol and the thyroid hormones, and insulin. I mean, every cell in the body has receptors to those hormones. And the other thing to remember is that these hormones can interfere with each other. So last year we talked about how progesterone, that's a steroid hormone, that can interfere with the action of insulin, causing gestational diabetes. And we see gestational diabetes in dogs and cats. If a patient has Cushing's, the steroid cortisol will interfere again with insulin. So patients with Cushing's are at high risk of developing diabetes mellitus because the insulin just can't work. So something else that some hormones have in common is this idea of negative feedback. And negative feedback is the way that hormones regulate themselves. It's the way they prevent their levels. It keeps their levels from just getting out of control. And we compare it to like the thermostat in your house. You don't want your house to reach 90 degrees and 100 degrees and 110 degrees. The thermostat, once you reach a certain temperature, the thermostat will, via negative feedback, will turn off the heater. And then as the temperature drops below that set point, then the thermostat detects that and the heater kicks on again. So you'll see with thyroid hormone and cortisol, you'll see negative feedback, and it'll help you understand some of the tests we do to diagnose these disorders. So let's begin with the thyroid gland. So we'll review that, and then we'll talk about hyperthyroidism and hypothyroidism. So this little gland is a little butterfly-shaped gland found on your neck, and I call it the gas pedal of the body. It controls metabolism, so the rate at which you burn energy. It allows you to generate heat. It affects metabolism of different nutrients, and it's important for normal growth and development. People who are hypothyroid are always cold. As an example, they are wearing sweaters even on a hot summer day. There are actually two thyroid hormones that your thyroid gland produces. One is called T3, and one is called T4. They both contain iodine, right? This mineral called iodine, they both contain. In fact, that's essential to their formation. T3 is the biologically active form. That's the form that actually does something. T4 does not do anything. It's T3 that's the active form. But the thyroid gland actually makes very, very little T3. By the way, this is why your salt contains iodine, or they're calling it iodide. That way, you're getting the iodine you need for your thyroid. So your little thyroid gland should thank you every time you sprinkle salt on your food. There's a few other little players here. So of course, we got T4 and T3 coming from the thyroid gland, but you also have your pituitary gland is releasing a hormone called thyroid stimulating hormone. So that's what TSH stands for. It stands for thyroid stimulating hormone. And its job is when thyroid levels get low, its job is to tell the thyroid gland to make more thyroid hormones. This picture makes it look like it's coming from the hypothalamus, and that's not true. The hypothalamus makes its own hormone that tells the pituitary gland to make TSH, which tells the thyroid gland to make thyroid hormones. So, but we don't need to know about that. But it is important to know about TSH because we use that to diagnose thyroid problems. So again, the thyroid gland doesn't make a lot of T3. It mostly makes T4. And most of that T4 cannot leave the intravascular space because it's bound to some big protein. I don't know if it's albumin or what, but it's bound to a protein. There's a small percentage that is not bound, and we call that free. It's free T4. That can leave the blood vessels where it goes to probably every cell on your body, and somehow the cells convert it into T3. And I don't know if that's every cell or just liver and muscle or skin. I kind of get the impression that most cells convert it. They chop off one of those iodine molecules, and now you have T3, which is going to then make different cells do different things, right? It's going to make your bones and muscles grow. It's going to affect your keep your skin healthy and not all dry and flaky. So a lot of different things. But that T4, T3, the free T4 remember that because that's going to come in handy in a moment. And this just shows you most blood work you do, most standard chemistry panels will have total T4. So that's measuring both the free and the bound, right? It's measuring the T4 that is free, which is a small amount. It's mostly measuring the amount that is bound to some protein and cannot leave. It's too big to fit through your endothelial cells of your blood vessels. And then sometimes, though, we need to be a little more exact, and we can measure the free T4. It's a little more sensitive of a test. It's also a lot more expensive. And so in practice, as I said, we commonly measure total T4. That T4 is the reservoir for T3. So we can use, if T4 is normal, then we can assume T3 is normal. But if T4 is high, then T3 is high, and so on. And just as an example of when we would use T4, you'll see this a lot where the veterinarian is looking at chemistry reports, and there's a cat that's been losing weight, maybe has a little bit of a heart murmur, vomits occasionally, and the T4 is right here. It's right here. You're like, well, it's normal. It's in the high end of normal, but it is normal. Is this cat hyperthyroid or not? Well, then the veterinarian calls the owner and says, I think we should run the free T4 test. And that test is a lot more expensive, but it's a lot more sensitive. And it's amazing how often, and I don't know why, but you run the free T4 and it is clearly abnormal. And again, I used to know why, but now I don't remember. I just know that it's really useful, and that total T4 can be a little frustrating sometimes. And the same is even true with the opposite problem for dogs that are hypothyroid, that have a low thyroid. Same thing will be this sort of gray area, low normal total T4. And so we ask for a free T4. Of course, sometimes you get this where it's still low normal, but we'll talk about that when we talk about hypothyroidism. And this is just showing you that negative feedback. So as T4 levels increase, that's going to have a negative feedback effect on the pituitary gland. And so the pituitary gland will make less thyroid stimulating hormone. It also, the T3 and T4 also feed back to the hypothalamus and tell it to release less of its hormone, which is called thyroid releasing hormone. But we don't use that for anything. We don't use it for any diagnostics, so who cares? But again, and then as thyroid levels start to drop, as T3 and T4 levels start to get low, then that negative feedback stops, and now the pituitary gland is free to shout at the thyroid gland to make more thyroid hormone. So for some difficult to diagnose cases of either hyper or hypothyroidism, sometimes if the total T4 and the free T4 is just right on the borderline, and we really cannot say if the animal is hyper or hypothyroid, we can measure T3 and thyroid stimulating hormone levels, which is very cool because when I graduated, that test didn't exist. And that's why a lot of dogs were probably overdiagnosed with thyroid issues. So the TSH test is really awesome. So just imagine we have a dog who is truly hypothyroid. Would you expect their TSH levels to be low, normal, or high? So just take a second and think about that. What would you expect them to be? I'll give you a little hint. The hypothyroid dog is going to have low levels, right? This is the hypothyroid dog. They have low levels of T3 and T4. There's very little T3 and T4. So what is the pituitary gland going to do? It is going to have high levels of TSH, high levels, because there's no negative feedback taking place. So it knows there is no thyroid hormone. So it is shouting, hey, thyroid gland, make more thyroid hormone. So we'll talk about our first thyroid disorder. That's hyperthyroidism. You will probably only see this in cats. Valerie told the story of a dog who was eating a raw diet and was maybe consuming thyroid gland, and so that dog was hyperthyroid. But most cases will be cats, and it's because they develop a tumor on their thyroid gland. It's just the size of a sesame seed, maybe a small pea. So it's usually benign, except it's making lots and lots of thyroid hormone. A small number of cats, it'll actually be malignant. And we'll talk about that. So the pathogenesis of this is these high levels of thyroid hormone are going to result in, I tell clients, having the pedal to the metal, if we use our gas pedal analogy. That abnormally high metabolism is going to affect multiple systems. So what are some of the typical clinical signs that you've seen? And you've probably heard of, patients are really hungry. I mean, they will eat everything in sight. They will be losing weight. They'll be a little crazy, really active. Sometimes they're just yowling in the middle of the night. They tend to get kind of a scruffy little hair coat. I found these little videos that I thought they're cute. They're a little bit cartoony, okay. So if you'd like to watch them, there's one I'm going to have you watch because it actually will show you a cat with hyperthyroidism. We're not going to look at this one, but it is kind of cute if you want to watch it. So like we said, those are some clinical signs the owner may report. And here's what we may find on physical exam. Tachycardia, all this excess thyroid hormone can cause that condition called hypertrophic cardiomyopathy, where the left ventricle gets thicker and thicker and thicker, and that can cause heart failure. The thyroid gland, you should, if you're not, you should get in the practice of just running your fingers down the cat's trachea and just mainly to feel normal, because most of the time you won't feel anything, but then you'll feel this little slip or blip of this little sesame seed passing through your fingers. And you'll say, did I just feel that? And you probably did. But you've got to check hundreds of cats before you'll ever notice it. Some of these cats will also develop hypertension as part of the hyperthyroidism. And I tell you all this because, let's say you're working at a clinic and someone comes in for a vaccine appointment and you notice they look like this cat. Well, you might want to ask them, like, maybe they're just there for their distemper vaccine, but it's a chance for you to engage them in conversation and be an advocate and say, hey, maybe we should, get Dr. Mathis to take a look. Looks like your kitty cat might have something going on, because clients will think this is just normal old age. And the cat has a great appetite. They're not acting sick. So So this video I think is useful just because it's a cat who doesn't look, he doesn't look that bad, but he's showing some early signs of hyperthyroidism. So
this is Ringo. He belongs to one of our nurses, Kim, at Vet's Clinic. And he's had a little bit of a problem recently with a condition called hyperthyroidism. So we thought it would be really useful to tell other owners and clients about the condition that occurs mainly in cats, some of the signs that you'd be looking out for, and also what are the options when you find out your cat has this disease. So the first thing that Kim noticed with Ringo, as you can see here, is his appetite was very big. He was always a good eater, but suddenly his appetite had increased. At the same time as this, he'd started to lose weight, and this was a bit of a concern as to why this was going on. The other thing she'd noticed was that his drinking had increased as well, and his activity levels were more than they'd usually been in the past. These raised some alarm bells with us at Vet's Clinic, so we thought the best thing to do would be to take a blood sample from Ringo to check what was going on internally. Now, the only problem with this is that these signs aren't only associated with hyperthyroidism, so we had to give quite a general blood sample first to try and narrow down what was going on. We did find, on taking the blood samples, that Ringo was indeed hyperthyroid, so his thyroid hormones. The thyroid gland is on either side of the windpipe in cats and dogs and in humans as well, and it was overactive, which meant that we needed to give him some treatment for this, and we needed to look at his ongoing treatment for the rest of his life. So the first thing that we did was we started him on some medication. Now, there's lots of options for treating hyperthyroidism. One is taking some tablets, which is every day for the rest of the cat's life, but the levels must be monitored regularly. So he's been coming in for blood samples every 3 months to check that we've got the right level for him. Other options, if your cat won't take tablets, are surgery to remove the thyroid gland. We've also got food, which you can control, but this wasn't useful in Ringo's case because he's one of many cats in the household, and it would have been very difficult to make sure that he was getting the food and not the other cats. And the last option would be some radiation treatment. That's not something that we currently offer at Vet's Clinic, but it is in specialist centres. I'm very pleased to say that now Ringo's been on treatment, he's doing an awful lot better, but we'll need to continue monitoring to make sure that he's well for the rest of his life and make sure that he's not developing any other conditions. But as you can see, he's now a much happier cat.
there's a lot. She kind of covers the whole chapter there, the whole section of the chapter. So yeah, she mentioned, you know, there are other things that could cause this, you know, not just hyperthyroidism. You know, diabetes could look like this, certain protein losing, intestinal diseases could look like this. So we always have to, you know, you don't just run the total T4. Because that small number could be malignant, you do want to do chest radiographs to make sure that we don't see evidence of metastasis to the lungs. A lot of these guys have hypertension, so we want to check for that. A lot of these guys have hypertrophic cardiomyopathy, which may need to be treated with some of the medicines we talked about the other week. And this is a big one. So this usually happens in older cats. Well, what else happens in older cats? Chronic kidney disease. And the problem is if a cat is hyperthyroid and has chronic kidney disease, you will not see the chronic kidney disease because the hyperthyroidism will mask it. All that jacked up metabolism is going to make the kidneys look good when you do blood work. But the moment you treat the hyperthyroidism and you slow down that heart and maybe that helps lower the blood pressure, then we suddenly find that the poor little kidney is actually not in great shape. And so we say that treating hyperthyroidism can unmask chronic kidney disease. Now, this is an important point because you might think, oh, well, then don't treat the hyperthyroidism, right? Then that way the kidneys are fine. And that's not true. That hyperthyroidism is not good for the kidneys. It's making it look good, but it's really wearing out the kidneys. It would be far better to get the hyperthyroidism under control, and then then if it turns out that the cat also has kidney disease, is to treat that as well, the way we discussed. Diet, increasing water intake, you know, sometimes treating the hypokalemia and things like that. But it's an important thing to tell owners as well. And I always try to tell them this may uncover other problems, but it's going to be better in the long run. Treatment falls into two categories. Palliative is management. You're not actually curing anything. So we'll just talk about that one first. There is a medicine you learned about in pharmacology called methimazole. It can come in a pill form. It can be compounded into a chicken flavored liquid. It can be made into a transdermal gel. So clients can just rub it on the ear. And it usually has to be done every 12 hours. Maybe you can get away with every 24 hours. And what it's doing is it's blocking the synthesis of T3. So I guess T4 gets down to the cellular level. Well, no, I guess it's actually blocking. It must be blocking it in the thyroid gland. So it's probably blocking the production of T4. Is probably what it's doing. And then, but it doesn't cure anything. It doesn't. The tumor keeps making excess hormone. We're just blocking. What I should say is that the tumor is trying to make thyroid hormone, but we're blocking it from doing it. But it's still there. The tumor is still trying to. And when we use something like methimazole and other products with other diseases, we need to tweak or titrate the dose. So it's not like we say it's not like antibiotics where generally we put them on a dose and we say see you later. In this case, this is something that they're going to be on forever, for life. So we'll start the cat on a dose of methimazole, and then they'll come back in 2 weeks, and we'll check their levels. And if the levels are too low, we bump up the dose. If the levels are too high, we decrease the dose. And guess what? Then we're going to recheck again in another couple of weeks. And it's important clients understand this because we'll often see over time that as that tumor grows, that we're going to need to increase the dose. Another palliative approach is called the YD diet. That's a diet that Hill's Science Diet makes. And it works because it's like the opposite of salt. It is restricted in iodine, and that limit will limit how much thyroid hormone the tumor can produce. But like the woman said in that video, it doesn't work very well if you've got a whole bunch of cats because with this diet, that's all the cat can eat. If the cat starts eating this cat's food and that cat's food, it won't work anymore. And so it's really only good for like a one cat household. But a lot of veterinarians don't like it very much. A lot of cats don't like the taste. And also there's no long-term studies about its effects. So just so you know, for curative, there is surgery that can be done where the surgeon goes in and removes the tumor. The danger is that if you remove too much, then now you've made the cat hypothyroid, and now they have to get a thyroid supplement. Really the best for if a patient has, the book says if a patient has no other problems, no other, say, kidney problems, the treatment of choice is radioactive iodine treatment. I've been told that one's okay, even if they do have kidney problems. You just have to, you don't just jump into radioactive iodine treatment. You put them on methimazole first, and if things seem stable, then consider radioactive iodine treatment. We're not going to watch this video, but it's interesting. It's from a veterinarian whose clinic does this radioactive iodine treatment. The way it works it's a radioactive iodine, and what happens with iodine? It's going to get taken up by the thyroid gland to make thyroid hormone. Well, something about this radioactive iodine is it will not get taken up by the whole thyroid gland. It will only get taken up by the cancerous cells, and it will kill them. So it's a very targeted treatment, and it's just an injection. There's no anesthesia. There's no surgery. Chico Hospital for Cats offers it. You drop your cat off, and they stay there for a few days. It's kind of an expensive treatment, and also for the first, I can't remember, for a certain amount of time, maybe this is while they're just at the Chico Hospital, the poop is radioactive. It's not really radioactive, but I think that's a good way of, well, actually it is. It doesn't glow green, but it is radioactive because it has this kind of radioactive iodine in it. And so I think even when you go home with the cat, I think they say for the first, week or so to wear gloves, and there's some safety precautions with it. But overall, really great treatment because it cures the problem, but kind of expensive. Okay, now let's talk about the opposite problem, hypothyroidism. This is mostly going to be seen in dogs. I want to say you'll only see it in dogs. This is not from a tumor. It's either from the immune system slowly destroying the thyroid gland, or the gland just atrophying. And so again, it's kind of the opposite of hyperthyroidism. Now we have these decreased levels of thyroid hormone. That's decreasing metabolism, which is going to affect so many different systems. What are some of the clinical signs that you've seen or physical exam findings? Often owners may not even notice there's anything wrong. But the big signs that the owner may notice is that the dog just is kind of dull, dull physically, dull mentally. They don't want to play. They don't want to go for walks. They're always tired. They're gaining weight. Their coat looks kind of dull. I had one dog, this was the only sign. The dog had this head tilt, and that's not a cute head tilt. It was clearly an abnormal head tilt. And it was a golden retriever, and I had read somewhere that like low thyroid will show up as a head tilt. And sure enough, the dog had low thyroid, and we treated it, and the head tilt went away. It was weird. And again, it's kind of dull coat. They're not itchy. So if you see hair loss with no itching, think endocrine, right? So you'll see another disease in a little bit that also causes hair loss. But if there's hair loss with no itching, hypothyroidism would be on my list. And this cartoon is a little mean, but it contains some truth. Clients will think, they'll say, oh, my dog's gained so much weight. And then you ask them about the appetite, and they're like, oh, his appetite's great. He'll eat anything. He's always starving. That dog is probably not hypothyroid. That dog is probably like this gentleman here. Dogs that are hypothyroid, their appetite's not great, and they're gaining weight. The diagnosis, sometimes total T4 will tell us, sometimes we need a free T4, and sometimes we need to measure that thyroid stimulating hormone. And if we see low, even borderline low T4 and free T4 and a high TSH, then we can be pretty confident. But as I said, this disease used to be overdiagnosed. Maybe it still is overdiagnosed. It's easy to treat, but it can be a little hard to diagnose. And sometimes you'll see other abnormalities on a CBC or chemistry panel. For example, elevated cholesterol levels. We see that with hypothyroidism. Treatment, there's really just the one treatment, and that's thyroid supplement. And like the cat with hyperthyroidism, we start a dog on a conservative dose, and then we tweak the dose. They come back. This one's important because it's kind of unique. They have to come back 4, 5, 6 hours after the morning pill. You can't schedule a blood check at 8 a.m. unless they gave the pill at 2 a.m. And so that's really important. It'll annoy the client if they come in to have the blood levels checked, and then we discover, oh, this was scheduled at the wrong time. And there's a third thing I want to mention called the sick euthyroid syndrome, which I think we've talked about before, but I wanted to bring it up. You can have a patient, there is nothing wrong with their thyroid gland, but their thyroid levels, their T4 levels will measure low. They will be abnormally low. And that's this thing called the sick euthyroid syndrome. Euthyroid means, remember, eu means good or healthy. So this is a good thyroid that is measuring like it's sick. And so it's really any sort of illness, cancer, kidney failure, liver failure, leptospirosis. I mean, almost any sickness for some reason will cause the thyroid gland to make less hormone. There's nothing wrong with the thyroid gland, but it's something we keep in mind. We'll have patients that are really sick. We don't know why. We'll do a chemistry panel, and the thyroid levels will be low, but we know that probably not a thyroid issue. All right. So I don't have any little review. I don't have any little Quizlet or anything like that. I will have a little Kahoot a little bit later, but let's talk next about the pancreas and this disorder, diabetes mellitus. So last week we talked about the exocrine pancreas, right? It makes these enzymes, lipase and amylase and trypsin, right? Those go into the small intestine and they help you digest whatever you've eaten. The pancreas is like two organs in one. It also has an endocrine portion that makes these hormones insulin and glucagon. And we don't really, and they basically do opposite things, but we don't really care much about glucagon. So not as far as disease goes. So the, hold on one second here. All right. The well, so to help understand what diabetes mellitus is, you need to understand normal. We need to understand what sort of the normal function of the pancreas is. So the cells in your body all require some sort of fuel, right? The fuel could be sugar. The fuel could be some sort of a fat. Some tissues can use sugar or fat as a fuel. What tissue depends exclusively on sugar? So that's your brain. Your brain and your whole nervous system have really high energy needs that they cannot use fat. They can only use glucose. And diabetes mellitus mostly involves the metabolism of sugar, glucose. So that's what we're going to focus on we're going to focus on sort of the sugar part of the situation. Where does glucose come from? It comes from carbohydrates. It could be a candy bar, a potato, starch. For us, same, even grass has glucose in it. It's just that our enzymes can't break it down. And so the pancreas makes insulin, and tissues cannot absorb glucose without insulin. It's produced by the pancreas as part of the body's natural blood sugar regulation. And you can think of insulin as being like a lock and key. These could be these cells. This could be a liver cell, a brain cell, a skin cell, a whatever cell. Okay, these are all different cells with these little insulin receptors. And then here comes insulin, this little yellow ball. And when it fits into the receptor, now suddenly this channel can open and allow glucose in, right? So all these ones here, glucose can come in, but these three, insulin has not activated the receptor yet, and so the channel is closed. Sugar will stay, it'll stay in the bloodstream until those channels open. It cannot be used by these cells until insulin opens the door. And I just kind of wanted to address a common misconception that I hear from everybody, not so much students, but some students and from clients. So when a patient has diabetes mellitus, are they going to be gaining weight or losing weight? That's one question. And are they going to have high blood glucose or low blood glucose? And it's amazing how many people think these patients are going to be gaining weight and having low blood glucose. It's the opposite. These patients they're eating a lot and they're losing weight, and their blood glucose is high. And we'll talk about that. I think when people think that diabetes causes low blood sugar, what the mistake, I think, is they're thinking of the treatment. The treatment, insulin, can cause low blood sugar. But diabetes will never cause low blood sugar. So what's going on with diabetes? Well, there's actually two different kinds of diabetes, even though they're treated very similarly. One kind of diabetes is when there's a reduced number of pancreatic beta cells. The beta cells are the cells that make insulin. And so that's what we're seeing here. There's just reduced numbers, so they're not making enough insulin. This is also called type 1 diabetes or insulin-dependent diabetes. Mostly you'll see this in dogs. This happens, a dog could have pancreatitis, and that could result in this. More commonly, there's just a kind of an immune-mediated gradual destruction, well, I think it's gradual, where the pancreas is just toast. It's just not going to make any more insulin. And so patients with type 1 diabetes, they're going to need insulin for the rest of their lives. With type 2 diabetes, here there actually is insulin. The problem, though, is that the cells won't respond to it. This is called type 2 diabetes, also called insulin resistant, because the cells are resistant to insulin. Sometimes it's called non-insulin dependent. This is only in cats. This is not a dog disease. You'll never see it in dogs. And it's it's got many different factors. Genetics plays a role. But obesity is a major factor. And the same goes for humans with this condition, that something about obesity will prevent insulin from being able to act. It prevents the receptors from responding. And we'll talk a little more about type 2 in a moment. So all of the clinical signs and the pathogenesis, well, they're resulting from the fact that now these cells cannot utilize glucose. That is not how you spell lethargy. But we see these signs. Their patients are eating a lot. they're urinating a lot, they're drinking a lot, they're vomiting, they may be overweight. Well, it says obesity, but of course they're going to be losing weight. That cat doesn't look very lethargic to me, but anyway. And all these signs are a result of the pathogenesis. Now we've got, glycosuria. That's glucose in the urine. Well, that's going to have an osmotic effect and draw additional water into the nephron, and so your patient's just going to make more urine. It also increases the risk of them getting a urinary tract infection. These patients, they can't use glucose. So they're going to start burning fat because that is an alternate energy source. The problem though is then fat creates ketones, and we'll watch a little video in a moment about what ketones do. They are acidic, and as we've learned, the body does not like when your pH changes. We get weight loss with polyphagia because these patients, they are urinating away all their groceries. And there are other signs that are kind of important to know, that are kind of unique to cats and dogs. Cats, this is kind of a weird and horrible development. It's called the plantigrade stance. And you see she's basically like walking on her hock, right? That's normal. That's how she's supposed to walk. But cats with diabetes, it's kind of related. I mean, I don't know if the ligament is getting laxity or what, if it's just amazing muscle weakness, I'm not sure. But this is kind of a horrible thing you may see. I think it can get better. I haven't seen it that much. This I've seen a lot. Dogs, they'll get cataracts and they'll get them overnight. I mean, the dog will be fine and then blind in the morning. And that'll really stress owners out because now they've got this blind dog. Dogs can do quite well blind, but it's a very emotional experience for owners. So how do you diagnose it? Well, diabetes is fairly easy to diagnose. It's not so easy to treat, but it's pretty easy to diagnose. We get high blood sugar and you get sugar in the urine. Now remember, cats and some dogs can get so stressed out that they'll get hyperglycemia and a stress-induced hyperglycemia and the glycosuria. Well, that looks just like diabetes. So do you remember there's a test we talked about that you can use to tell the difference? And it's the same test we use that we can use to monitor diabetic patients to kind of get a sense of how their blood sugar levels are over time. It's called the fructosamine test. And as a comparison, a blood glucose test, that tells you what the blood glucose is right now. Tuesday at 10 a.m. Here is Spot's blood glucose. Fructosamine tells you what Spot's blood glucose was for 2 weeks. It's sort of this unusual. It's bound to this unusual kind of protein, and it gives you this 2-week average. So if a patient had glycosuria and hyperglycemia, but they're really stressed out and they're showing no other signs, there's no weight loss, there's no increased thirst, no increased appetite, we're going to probably say, well, let's make sure it's not early diabetes. We do the fructosamine test and it tells us blood sugar levels have been totally normal the last 2 weeks. Okay, good, we have our answer. But you can also use it because, again, diabetes can be really hard to treat. Again, we're tweaking these insulin levels. We haven't talked about that yet, but we can use the fructosamine. There's something much better. The blood glucose curve is much, much better than the fructosamine test. but we can still use this to help us adjust, not to adjust doses, but to get an idea of how good a job we're doing. Okay, so what is the treatment? The treatment is insulin. That's part of the treatment. It's usually going to be every 12 hours. Glargine is one kind that's used. It lasts a long time. And again, we got to tweak the doses, so we got to do rechecks. And how do you know? Because you can't just come in and get a glucose level. You have to do what's called a glucose curve. And what that means is, and you can teach the owner to do this. You get a blood sample in the morning before the animal eats. That's called a fasted blood sample. Get that at, say, 8 a.m. Then the animal eats, and then every 2 hours, we get another blood glucose sample. And what we should see, actually, it should be the opposite. We should see the blood glucose levels. We should see the blood glucose levels go down, until about 6 hours later, when the blood glucose levels should be at their lowest, and then the insulin starts to wear off, and now blood glucose levels start to go back up again. And then we can look at that. We can look at, well, how high was the high, how low was the low, and we can determine, are we over treating with insulin? Are we under treating? Do we need to adjust the dose? So, and in some cats, not dogs, in some cats with type 2 diabetes, if it's recognized in time and treated with insulin, they can actually go into remission. And so it can actually be cured. But that's only a minority of cases. Another essential part of treatment is nutrition. We don't want to just start giving them insulin. We want to look at their diet. Those of you who have family members with insulin, they need to have very regular habits. They have to eat the same thing, or not the same thing, but they need to eat at the same time every day. They need regular exercise. They can't be eating whenever they want, or even exercising whenever they want. And the same is true for our dogs and cats. They can't just be snacking all day. For cats, we actually use a high protein diet. So if a diabetic cat is, we would start them on something, well, I like MD, but Dr. Lisa Pearson does not like MD. So you may find some veterinarians who don't like one food or another, but I sure like, Dr. Pearson gave a pretty good example of why we use a high protein food. And you can read that to yourself. But dogs, it's different. We actually use a high fiber food. With a high fiber food, when we give that insulin injection, and something about high fiber food, we don't get this sugar rush. We get more of a prolonged absorption of insulin, which is going to result in a more prolonged absorption of glucose. So dogs get high fiber, cats get high protein. Now, this is a particular form of diabetes when diabetes just gets out of control. And so this may be what walks in your door tomorrow. The diabetes is so out of control, ketone levels are so high that we've developed what's called diabetic, or I wrote diabetes, it should be diabetic ketoacidosis. Diabetic ketoacidosis. And in really severe cases, the patient will be, they won't want to eat. They'll be anorexic, which is horrible because they're still diabetic, and now they're getting nothing. So they'll burn even more fat, and the DKA will get even worse. They're depressed, they're vomiting. Treatment is pretty complex. Sometimes we do an insulin constant rate infusion, fluid therapy, correct electrolyte abnormalities, maybe give them some sodium bicarbonate. It's pretty complex. And this little video is about humans, but much of it applies to animals.
have type 1 diabetes, it's something you're going to manage, mostly with insulin, a hormone your body doesn't produce when you have type 1 diabetes. By now, you probably know how and when to give yourself insulin. And if you have an insulin pump, you probably know how to maintain it. But do you know how to tell if something's not working? That's what we'll be looking at. You eat carbohydrates to fuel yourself with energy. Your body breaks down the carbs into sugar, which then goes into your blood. Think about it like filling up the gas tank in a car. When you eat, your body stores the carbs to use as energy when you need it later, like filling up the gas tank. Insulin is what opens the tank to let the gas in. As someone with type 1 diabetes, you don't produce insulin naturally, so the sugar doesn't get to where it's supposed to be, which is why you take insulin. If you're not getting the insulin you need, the sugar you eat stays in your blood instead of being stored in the tank. When this happens, your body won't have the fuel it needs when it needs it, and your body will seek out alternative sources to break down into fuel. One of the first sources it looks for is fat. Except when your body breaks down fat, it leaves ketones in your bloodstream that make your blood acidic. Together with high blood sugar, acidic blood from the ketones can make you sick and put your body in a state of diabetic ketoacidosis, or DKA. And DKA is really, really serious. It can even be fatal. The most common reasons for DKA happening are developing type 1 diabetes, missing taking your insulin, getting an infection, and malfunctioning equipment. Your body will give you plenty of pre-DKA warning signs before you're in serious danger. You may pee more than usual, which is your body getting rid of the sugar that isn't making its way into your cells. You may feel thirstier than usual, which is your body diluting the unused sugar in your bloodstream with water. You may find yourself breathing faster, which is the way your body tries to compensate for acidic blood. And you may feel tired and weak. If you notice any of these warning signs, check your blood sugar and also check your blood or urine for ketones. If you are worried or you're not sure what to do, call your diabetes care team or go to the hospital. Remember these easy steps to prevent DKA. Test your blood sugar regularly. Always take your insulin even when you're sick. If you are sick, stay hydrated, and you may need to take more insulin than normal. If you wear a pump, check regularly to make sure it is connected and working. And if you notice any of the DKA symptoms, check your blood or urine for ketones. Want to know more about DKA?
Okay, let's get a little too about humans. And I just want to call your attention to something that she said, which is you start to breathe faster, and that's something we talked about last year. Your respiratory system can try to get rid of acid by blowing off carbon dioxide. Carbon dioxide, when it mixes with plasma, can form carbonic acid, and so we did that little experiment where we made soda, basically, so you could see how carbon dioxide is acidic. If you get rid of it, it will make your body less acidic. So you'll see these dogs that come in that are diabetic, and you'll see them breathing a little more deeply than you might expect. They could be in diabetic ketoacidosis. All right. So I'm going to try, I am so behind, as I'm sure you are too. I will try to create a little Kahoot. Again, this is just something very basic, just to let you kind of check your understanding. You should be making your own Kahoots and your own study guides and things like that. But I know it's nice sometimes just to be able to stop and check your understanding. So I'll try to get something up by the end of the weekend, okay? And we're just going to continue here, all right? So you can always hit pause if you want, but I'm just going to continue. And hopefully my computer doesn't crash, because that would really suck. The adrenal gland. Okay, so this is this little gland. Of course, it's found sitting on top of your kidney like a little hat. It's actually two completely different glands. It's like a chocolate covered peanut. But the chocolate and the peanut are totally different. So we are more interested in the outside part today. It's called the adrenal cortex, because that makes two particular hormones that collectively are known as corticosteroids, cortico meaning cortex. And these two hormones are the glucocorticoids and the mineralocorticoids. Now, there's really only one of each that I've ever heard of. So there's really only one glucocorticoid, and that's cortisone. I will call it cortisol or cortisone. I know there's some little difference, but they're basically the same thing. And then the mineralocorticoids, and we'll talk about each of those. And aldosterone is really the only mineralocorticoid. As I'll say in a moment, if you hear the word glucocorticoid, it should make you think glucose, right? So it's going to have some effect on glucose. And a mineralocorticoid is going to have some effect on minerals. And in particular, the mineral is something you probably don't think of as a mineral, and that's salt, or rather sodium. So sodium is a mineral. We can go out in a desert and dig up, or wherever, and dig up a rock that is sodium. And so that's what aldosterone is working with. It also influences potassium, another mineral. It'd be nice if they called them, if it had called it an electrolyte corticoid, right? That would be a much better term, electrolyte corticoid. But I didn't name it, so. Both of them together are part of your adrenal stress response. This picture only shows you cortisol, but just I want you to, in your imagination, add aldosterone down in that picture there. So in this picture, just showing you what happens. So you're stressed, you got an exam coming up, you're being chased by a madman, I don't know, you're being chased by a bear. And what happens is your hypothalamus, you're aware, you're hearing things, you're sensing things, you're consciously aware of stress. And so your hypothalamus releases, I wrote CRT, I meant to write CRH. That's going to tell the pituitary gland to release a hormone called adrenocorticotropin hormone. Adreno meaning adrenal gland, cortico meaning cortex, and tropic meaning to have some effect on. And so this is kind of similar to thyroid hormone, right? We had that thyroid releasing hormone to the pituitary gland, and it had the thyroid stimulating hormone. So this is a similar setup. And ACTH then tells the adrenal gland, make cortisone and make aldosterone, because together they're going to help you deal with stress like this. Okay, so first let's look at cortisone. So it's named, the glucocorticoid is named for its effect on blood glucose levels. It's going to break down proteins and lipids. They'll be converted to glucose in the liver. Okay, that's cool. Also, this is going to help your body resist certain effects of stress. So it has sort of anti-inflammatory effects. It'll stabilize the cell membrane. In case you don't remember, this is what all the steroid drugs are based on. And by steroids, I should say glucocorticoids. Things like prednisone, prednisolone, dexamethasone, triamcinolone, hydrocortisone. Those are all based on cortisone, right? And we use them to reduce inflammation. We use them to stabilize cell membranes. At high levels, we use them to suppress the immune system. I don't know why that is going to help. That seems like that would hurt me during a time of stress, but I'm sure there's some reason behind it. And then the mineralocorticoids, Again, named for its effect on minerals, sodium and potassium. Aldosterone is really the main one you're ever going to hear about. And what it does, it gets released from the adrenal gland. It's going to target the kidney and cause the nephron to increase reabsorption of sodium. That means it's going to move sodium from the nephron out back into the bloodstream, and then water will follow using osmosis. Now, the kidney can't just, if it's going to take back to sodium ions, it needs to get rid of something. And so to keep things in balance, aldosterone will also facilitate the exchange of potassium. So some potassium ions will be secreted and lost in the urine, and some sodium ions will be reabsorbed into the bloodstream. The result of all this is sodium with water following the sodium is it increases your blood volume, and that increases your blood pressure. Again, that's helping. If you're being chased by this guy, right, being chased by this bear, you want to have good high blood pressure. And we see negative feedback here as well. As cortisol builds up, it feeds back to the anterior pituitary gland and says, hey, stop making ACTH. It also feeds back to the hypothalamus and says, okay, you too, stop making the corticotropin releasing hormone. Or I'm sorry, is that what is that? Whatever CRH stands for. Right. Now, why do you need to know this? Because it'll help you understand the tests that you will be responsible for when these are your patients. Okay, now let's talk about some of the disorders. Just like with the thyroid gland, we have a problem where there's too much, and we have a problem where there's too little. And in this problem, in this first disease, there's too much cortisol, and it's named after Harvey Cushing, a very famous physician. So it's been given his name, Cushing's disease. And we'll talk about some of the different signs. There's two possible causes, two possible etiologies for hyperadrenocorticism. They both involve tumors. Either you have a tumor on your pituitary gland, or there's a tumor on the adrenal gland. If the tumor is on the pituitary gland, it's making excessive amounts of ACTH, and then the ACTH goes to the adrenal gland and is telling it, make me some cortisol, make me more cortisol, make me more cortisol. And the adrenal gland is saying, how much more do you need me to make? And the pituitary gland is saying, shut up, I don't care, just keep making more. And so you end up with high levels of cortisol. The other thing we see is there's no tumor on the pituitary gland, but there's a tumor down on your adrenal gland, and it's just making lots and lots of cortisol. This could be iatrogenic as well if the veterinarian is over prescribing prednisone or giving injections of methylprednisolone, or if we're over treating with glucocorticoids, we can cause this as well. But we're mostly going to focus on these main two etiologies. And by the way, you'll probably never see this disease in cats. Okay, so again, the pathogenesis here is just related to, this is another hormone that affects multiple systems. It's just cortisol. This is not high levels of aldosterone. And it may interest you, why is the client brings you this dog has Cushing's. We don't know that. But why does a client bring you a dog with Cushing's? Are they concerned about this weird little belly? Are they concerned about the hair loss? Usually not. A lot of them may think, well, that's just her. That's just, she seems healthy. She's active. She's eating. The reason they come in is because she is peeing, or he is peeing all over the house. Polyuria, polydipsia is the main reason clients will bring these dogs to you. Their dog who always had great bladder control is now creating a lake of urine in their house. So is this condition ever an emergency? Like diabetes can be an emergency. It can be that diabetic ketoacidosis. Can this ever be? Well, yes and no. The patient will never be critical, but if they are peeing all over the house, we need to get that under control quickly, or they may, I don't know what they would do. They might decide to euthanize the dog. I mean, people can only tolerate, I hate to say it, but they may love their dog, but after a while, you may get one spouse who's getting a little sick of, cleaning urine out of the carpet. So, we get when a person comes with this complaint, it's a top priority. Most clients are wonderful, and anyway, see, I wish you were here. We could have a conversation about this. How do you diagnose it? Well, physical exam findings help, and then there are some very specialized endocrine function tests. The book mentions several, but we're just going to talk about the main one, which is called the low-dose dexamethasone suppression test. You learned about it last year, but we'll just review it. And then imaging. If you ultrasound the adrenal glands and you see this big mass, that LK stands for left kidney. Well, this dog has an adrenal tumor. And again, I won't go into great detail, but you can learn a lot by ultrasounding the adrenal glands. I'll bring this up again when we talk about treatment in just a moment. But still, how do you diagnose it? Because some dogs, they don't look like this. They don't look like this dog. They don't look like that dog, right? They're just peeing crazy amounts, and they are drinking crazy amounts of water. So, so we want to find out if they have Cushing's, and this test is pretty good. The way this test works is you take a blood sample. Usually starts in the morning because this is going to take 8 hours. So the owner comes by in the morning. They drop off their dog. You get a blood sample, and you write baseline on it. And then you give the dog a very, very small amount of dexamethasone. Remember, dexamethasone, the body will think it's cortisol because it is a glucocorticoid drug. So the body will think that it just got this surge of cortisol. Then put the dog away, give him some food and water, play with them, whatever. 4 hours later, you get another blood sample, and then another 4 hours. So at 8 hours, you get your third blood sample. So now you have one that is baseline, right, before the dog ever got any dexamethasone, and then a 4 hour sample and an 8 hour sample, and those go to the lab. And in a normal patient, the baseline sample will be normal, and then the 4 hour and the 8 hour sample will be really, really low levels of cortisol, because when you give that dexamethasone, it's going to cause feedback to the dog to stop making ACTH, which then they should stop making cortisol. So you're using the negative feedback to try to diagnose something. And I'll show you what I mean in a moment. So here's two dogs, two different results. So one of these is normal and one is abnormal. So here's a normal, well, I'll just tell you, right? So here's normal. Normal dog, dog does not have Cushing's. We get that baseline sample, and then we give him a little dexamethasone, and then that feeds back to his hypothalamus and his pituitary, and results in a big drop in cortisol. The abnormal dog, you give them dexamethasone, they don't care. You know, if it's the pituitary gland with a tumor, it doesn't care. It keeps making ACTH. If it's a tumor on the adrenal gland, it doesn't care. It keeps making cortisol, right? So these are the sort of results you would see. These are not, I mean, I made this deliberately. Don't show this to your coworkers, all right? I made this deliberately exaggerated. If you show them this, they'll say, no one would ever have these values, but I'm just trying to make a point. How do you treat it? Well, so this is what the book says. That's okay. I think things have changed a little bit. So it used to be very important that once we diagnosed Cushing's, then we had to determine, well, is it the pituitary gland or is it the adrenal gland? Where is the tumor? Where's the tumor? And if it was the pituitary gland, we could use a drug called Mediated that would actually destroy part of the adrenal. Wait, I'm sorry, pituitary dependent. Yeah, that's what the book says. Well, anyway, Mediated would destroy part of the adrenal cortex. It wouldn't really do anything for that actual tumor. But now a new drug came out called trilostane, which is also known as Veterol, and that will just inhibit the production of cortisol by the adrenal gland. Mediated actually destroys the adrenal cortex. Trilostane just inhibits. So it's kind of like methimazole. And then the book says if it's adrenal dependent, you can actually do surgery to remove the tumor, but then the patient will need, now you've made them in kind of the opposite problem. Now it's like they're hypoadrenocorticism. Most people, again, it's been a couple of years since I've, treated a case of Cushing's, but I think most people, they just all go on trilostane. The surgery is still discussed, but I think the beauty of trilostane is it can be used to treat either kind. It's still good to find out if it's where the tumor is, but I think trilostane can be used to treat either kind. Okay, and I just wanted to mention, and it's a lifelong, it's for life. And there's so much more we could say about hyperadrenocorticism, how there's so much we could say. One thing it'd be fun to talk about is that horses have their own version. Catherine did a discussion on this last year. It's not the same, it's not quite the same as, it's called PARS intermedia something or other. But so it's not exactly the same, but really a very kind of frustrating disorder. It does a lot of weird, Cushing's does a lot of weird things to dogs. But when treatment is successful, it's very rewarding. Okay. And then our final endocrine disorder is hypoadrenocorticism, named after Dr. Addison, who discovered it. And here we have the opposite problem. We have the adrenal gland is going to atrophy, and now we're dealing with both hormones. There is a inadequate amount of glucocorticoids and mineralocorticoids. There is a form of Addison's called atypical Addison's, where it starts out where it's only the glucocorticoids that are low, but that will always progress to full-blown Addison's. And we'll talk a little more about this. Primarily affects dogs. It's kind of the opposite of Cushing's, but that doesn't really help you. That's what Claire had. So Claire had hypoadrenocorticism. She actually had the atypical kind, so it was only affecting her cortisol levels. But I've seen dogs that looked like they had seizures, and it was hypoadrenocorticism. I've seen it in a 6-month-old puppy, and it can look very different. And that's why it's called the great pretender, because it will fool it will fool all of us. It can look like anything. A lot of endocrine diseases can have kind of odd, subtle signs, and this one can be very frustrating. Now, luckily, I called IDEX about this patient because I thought there's just something. There's like, 'cause every test we did was normal, and the moment I said standard poodle, they said check for Addison's. So, and we'll talk about that in a moment. So again, what's happening here, we have inadequate amounts of these stress hormones, and this is a very complex disorder. It is not a straightforward explanation, because you're like, well, why would low cortisol cause some of these signs? Some of them we can explain. So if you have no cortisol, well, then that reduces your ability to mobilize glucose and fat. And so I think that's why a lot of these patients can be weak. Claire was a little lethargic. The lack of aldosterone means you can't ever raise your blood pressure using aldosterone. So these patients will collapse. But these other signs, the anorexia, the polyuria, the polydipsia, the vomiting, the diarrhea, I can't necessarily explain that. Some of these patients, here's an example. These patients can have low blood pressure. That's going to reduce their glomerular filtration rate, right? That's how quickly blood is flowing through the glomerulus, and so that's going to cause various toxins like blood urea nitrogen, creatinine to increase, right? That's what we call azotemia, depending on what book you look at. But the polydipsia will create really dilute urine. And so you'll have a patient who looks like they're in kidney failure, right? They've got high BUN, high creatinine, watery urine, but it's not kidney failure, it's Addison's. And in some cases, these patients, everything falls apart so quickly that they're in what's called an Addisonian crisis. This is truly an emergency. You won't know it. When they come in, you're not going to say, oh, this patient has Addison's. You're just going to find they have really weak pulses. Their heart rate is really slow. That's weird. Why is their heart rate slow? Prolonged capillary refill time because their blood pressure is so low. What electrolyte will cause bradycardia? What electrolyte abnormality? Think high potassium. The blocked cat, he cannot pee. His blood potassium levels are going up, and that affects the action potential through the cardiac muscle. And so the heart just ends up beating slower and slower. These patients will often have elevated potassium levels as well. How do we diagnose it? In the perfect world, these patients will have, there'll be azotemia. Well, I shouldn't say perfect world. These are some things you may see. They'll have a perfectly normal CBC. And what I mean is, this patient will come in sometimes being really sick, and you would expect them to have a stress leukogram. And so stop and look that up if you don't remember what that means. A stress leukogram comes from the release of cortisol, and it makes neutrophils increase, and it makes lymphocytes decrease. So you'll have a neutrophilia and a lymphopenia. If a patient comes in who's really sick, the veterinarian is going to look at the CBC and say, that's weird. There's no stress leukogram. That's a clue that the patient has this disease. And then, especially in bad cases, well, I shouldn't say bad cases, but the classic case, they'll have elevated potassium and decreased sodium, because that's what aldosterone is supposed to do. It's supposed to reabsorb sodium and get rid of potassium. But if we're not sure, or even if we have these signs, there are other things that can cause hyperkalemia and hyponatremia. Believe it or not, whipworms can actually cause some of these signs. So we really want a definite or definitive diagnosis. And in that test, the specialized endocrine test we do is called the ACTH stimulation test, where we would take Claire, we would give her an injection of ACTH. In a normal dog, that should cause a big rise in cortisol levels. But if we did this test on Claire, she made no cortisol. It's a very bizarre experience to give a dog an injection of ACTH, and then a couple hours later, you get a blood sample, and there's almost no cortisol. You have your diagnosis. Treatment will depend. If they're in a crisis where their potassium is high and it's almost like they're going into shock, those patients need really aggressive IV fluids. We need to correct their electrolyte abnormalities. So they often need antiemetics and glucocorticoids. But once they're stable, and like Claire was never an emergency, but we knew she was eventually going to develop full-blown Addison's. So we just had her come back periodically to I can't remember, I think we were checking her potassium levels or her cortisol levels, I forget. But eventually we're like, yeah, she is now officially Addisonian. And so we started her on a mineralocorticoid supplement. Again, last time I checked, it's an injection that the owner will bring the dog in like every 25 days. It's kind of an odd timing. And then you give this injection that acts as a slow release mineralocorticoid. So it's kind of like a slow release aldosterone. And then some of the dogs, they also take a little bit of prednisone every day. Not much, just like she would take like a quarter tablet of a 5 milligram prednisone, because she's not making her own cortisol. So we're going to give it to her. And then you may find that during times of increased stress that we need to increase the dose. And so I have this little question here of, well, why would the veterinarian increase a dose if this dog were boarding? Well, anything that's stressful, boarding, fireworks, a long car ride, the veterinarian may say, I just want you to bump up her prednisone dose a little bit to help her deal with this stress. Otherwise, diarrhea, vomiting, some of these symptoms may come back. All right, that's it for endocrine diseases. Those are some of the most common disorders you will see. Some of those you'll see several times a month or several times a year, depending on where you work. Okay, so now we'll talk about the immune-mediated diseases. Now, you remember that your immune system has a job. Its job is to tell self from non-self. Is this part of my human, or is this part of my body, or is it not? And there's little markers that all cells in your body have, and they're called little self markers. The MHC stands for major histocompatibility complex. But anything foreign is going to have its own little markers that we'll call it an antigen. That's going to make the immune system recognize it as being non-self. And remember, antigen means antibody generator. Now, there are so many immune-mediated diseases, and as we've learned, even things like pancreatitis and hypothyroidism have a little bit of an immune-mediated aspect to them. But we're looking at some really kind of weird, full-blown, scary diseases, and just two. We're going to look at immune-mediated hemolytic anemia, and we're going to look at myasthenia gravis. So immune-mediated hemolytic anemia, it's just one of the many causes of hemolytic anemia. We can have hemolysis where the immune system is not involved, but immune-mediated hemolytic anemia is the most common cause in dogs. And so, like a lot of other immune-mediated diseases, this can be primary or secondary. Primary means it's idiopathic. Secondary means there's some other problem. And again, what's happening with immune-mediated hemolytic anemia is the immune system, let's say this is a red blood cell, the immune system suddenly thinks it's now has this expression on its face. It thinks it's looking at a red blood cell and it sees this, right? It doesn't see this, it sees foreign invader. And so it mounts this attack, which results in antibodies being produced to attack your patient's own red blood cells. The majority of these are idiopathic. It just happens. You wake up one day and suddenly you're attacking your own red blood cells. I had a dog once, a patient who had heartworm disease, but that's not how he presented. He presented with hemolytic anemia, and we discovered, oh, this is not idiopathic. It's the heartworms are, I guess they're aggravating his immune system, and now his immune system is just shooting everything in sight. Cats, there's a kind of a parasite you learned about a year ago called hemotropic mycoplasmosis. It's a little blood, kind of an odd sort of a bacteria that will invade blood cells, but then that can trigger a hemolytic anemia. So what do you see? Well, of course, the patient's tired. They may have pale mucous membranes. They may have yellow mucous membranes from all this hemoglobin being released. They'll maybe have pale and yellow mucous membranes. Their heart rate's going to be really fast. The anemic blood will create the sound of a murmur, even though there's nothing really wrong with the heart. And often the spleen will get really big because the spleen is, part of the spleen's job is to take red blood cells out of circulation, and it gets big because it's working overtime and destroying all these red blood cells, which makes you think, well, could you just remove the spleen? But no, you can't. It's not the spleen's fault. Okay, so how do you diagnose it? Well, we did this little test when we were doing when we did the blood matching, right? We did we mixed serum with red blood cells from the Hasties horses. But this is all we need to do here is we just get a drop of the patient's blood. We don't need to mix it with anything other than a little saline or lactated ringers. A drop of blood from a lavender top tube and a drop of saline. And if we see these weird little chunks, that's autoagglutination. That's this. We're seeing all these red blood cells stuck together. And I should have put a slide, but you've seen it before. You can just see these clumps of red blood cells. The book mentions the Coombs test. The Coombs test has kind of fallen out of favor, and the book says this. The book doesn't seem to. The book seems to say this, so I'm just telling you. This is a test. We don't really need to talk about how it works, but it's used to try to diagnose IMHA, but the problem is by itself it doesn't really diagnose anything. It suggests IMHA, but it doesn't really confirm it. This test, autoagglutination, is the best test to diagnose IMHA. We treat them with lots and lots of glucocorticoids, or things like cyclosporin, What else? Chlorambucil. These are all drugs that are immunosuppressive. The problem is the immune system, so we need to tell the immune system to shut up. And so we give these immunosuppressive drugs, prednisone, dexamethasone, one of those. And then if that doesn't help, cyclosporin. If that doesn't help, chlorambucil. Anyway, some patients need a blood transfusion, fluid therapy, and if there's some underlying disease like heartworm or that hemotropic mycoplasma, we need to treat that. Some need oxygen, some need anticoagulants like aspirin or Plavix or maybe even heparin, so they don't throw a thromboembolus. Okay, I hope this works. Okay, here's our next, our one other immune-mediated disorder. This is one that everybody should know about, even though you may go your whole career and never see it. I've never seen it. I've run the test for it a few times. There's been a few times I suspected it, but I have yet to see a case of this. So we'll talk about myasthenia gravis. So first of all, though, let's review how does a motor neuron tell a skeletal muscle to contract? So here is the end of a motor neuron, and then this here is, a skeletal muscle in your arm, in your leg, whatever. What happens is in the end of the neuron, you have neurotransmitters, and they are going to float. They're going to get released, and they will drift over to the skeletal muscle, and they're going to bind with one of these acetylcholine receptors. And when they bind, that will tell these channels to open, and then sodium will rush in, and that will start an action potential in this skeletal muscle. And then immediately afterwards, acetylcholinesterase will inactivate the acetylcholine. And here's, I'm going to just show you here's a little acetylcholine. You're going to see it go and bind to that receptor there, right? So it does that, channels open, sodium rushes in, and then the action potential begins. Okay. Oops, that didn't work. Well, hold on. Oh, here we go. We're good. Okay, so myasthenia gravis, again, this is the immune system malfunctioning. And here the immune system is attacking those acetylcholine receptors. Myasthenia gravis, it's a disorder of the neuromuscular transmission. So it causes really profound muscle weakness. This is not a common disease, but it's more common in dogs than cats. Again, what's happening is the immune system is attacking those receptors. And so now acetylcholine, its job is to trigger a muscle contraction. Well, it has nowhere to go, right? I probably shouldn't have covered all the receptors. I should have just covered most of the receptors, but you can see what happens. Now there can't be very effective muscle contractions because this acetylcholine has nowhere to go. We call this acquired myasthenia gravis. There is a even less common form, it's a congenital form, where there's just, these receptors aren't even made. But that's not very common. So what will the signs be? Well, the big sign will be the patient will just be a floppy rag doll. I mean, they will be this will be the most profound weakness. They're not paralyzed, their neurofunction's normal. But they just can hardly do anything. A number of them will actually have mega esophagus. And this is, you're looking at a lateral x-ray of the thorax, and those arrows are pointing to the outline of the esophagus, right? The esophagus should normally be this very thin little tube. This is a big old floppy, dilated esophagus. And these are the sort of patients, you saw that video last week of the dog where just all this like undigested food came up. You know, it was just kind of sitting there in the esophagus. So this myasthenia gravis can cause megaesophagus, but you'll see many cases of megaesophagus that have nothing to do with myasthenia gravis. I had 2 cases of megaesophagus in one day. And one, well, I won't tell you what caused it. They both actually, one got better and the other had to get treated for life. But my point is, there are many things that can cause megaesophagus. This is just one. And if we see megaesophagus, we'll talk to the owner about ruling out myasthenia gravis. To diagnose it, we actually do a test that is measuring for antibodies against acetylcholine receptors, and I've done that test. I think it's just a serum test. And then treatment is a drug that's going to, our goal is we're trying to prolong the action of acetylcholine on any of those remaining acetylcholine receptors. Well, how do we do that? Remember the enzyme acetylcholinesterase. We can inhibit the action of acetylcholinesterase. That's what this drug does. I forget the name of the drug, but it'll allow acetylcholine to act to work a little bit longer, and it's amazing. I've seen videos in humans where they were so weak they could hardly walk, and then they got put on this drug, and they weren't great, but they could now, you know, they had a lot more muscle strength. Okay, and just showing you, you know, this is actually an advertisement for what's called a Bailey chair. And this is for dogs with megaesophagus. They just eat upright so that, you know, I think I may have showed you a picture of this last week, but they're just so cute. I wanted to show you that again. Well, the final thing we're going to say, I'm not going to really say much. I think you've learned a lot about infectious disease in like public health, for example, and other courses. So, so I'm not, the book does a pretty good job of explaining that, the required components and the steps of affection. You don't need me to read that to you. The book has that really kind of strange table with 30 different infectious diseases. But I like it, you know, I think this is a good way to end our little journey together. I realize we're not quite at the end of our journey, but this is our last lecture. And we began this journey together talking about why RVTs matter. And I hope by now you know why they matter and why they are essential for patient care, for a successful outcome. Cannot happen without you. And so I just gave, you know, again, we could spend all day talking about this. So everything that RVTs in my life have done and done for me and made me a better veterinarian. I was going to talk about, sort of contrast parvovirus, and this is a cat with ringworm. You know, one is a virus, it's deadly. The other is a fungus, it's not deadly. But in both cases, we needed to keep clients informed. We needed to keep patients eating and hydrated. You know, parvovirus, there's no medicine to kill a virus, or at least not. Sometimes we can use like Tamiflu, but most of it's all nursing care, you know, and keeping them hydrated, keeping them clean, keeping them comfortable so they can rest. They may be in pain, they may be nauseous, checking their catheter, trying to get the medicines in them, coaxing them to eat. Poor little puppy in an isolation ward gets really depressed. So what can we do to kind of remind them of what life is all about? We can't really take them outside, right? But so playing with them and just trying to you know, kind of tap into their core reason for being alive. you know, it's really, those are all important life-saving things. But you know, you're not here. I'm just sitting here by myself talking. So we'll stop there. We'll stop there. Okay, so I'll get this uploaded. I'll try to get those Kahoots written. If you got questions, you let me know. And it has been a pleasure working with you. But we still have one last leg in our journey. So I will I'll see you next Wednesday, and I'll see you next Friday too. All right, everyone, take care.